All right, good afternoon, everybody. We're just coming up on time. Let's see. Yeah, I've actually got the roll call sheet in my hands. All right. And it's October. Hard to believe. And all right, we got the recording going. Let's see. All right, let's do a quick roll call. I want to welcome everybody actually to the OEBB board meeting for October 1, 2024. Let's see, go agenda. Okay, so welcome everybody, and I'll begin by taking a quick roll call and a mic test for everybody. First off, there's me, and I am here. Enrique, are you here? Hard for me to see on this list. Now I see why Chair always complains. Seymour. Okay, there we are. Enrique, I do not see Enrique in my list. Okay, we'll come back to them. Cheryl Berger.
Here.
Thank you. Michelle Duberry. And not seeing Michelle yet. Come back to her. Sally, Sally, you there? Duefeld?
Yes, I'm here.
Thank you. Dr. Laura, Andrea Laura, are you here? I see you.
Yeah, I'm here.
Okay, thank you. Bonnie, you here? And I do not see a Bonnie yet. Tony is coming late. Tony, making sure you're not on yet. I don't see Tony. He'll be a little bit late. Susan Miller.
Present.
Thank you. And we only have one Sue now, Susan. Susan, great. Misty Wharton.
Hi there. Yes, I'm here.
There you are. I hear you.
Hello.
Thank you. And Robert Young. Anybody see Robert? Not yet. 2, 4, 6. 1, 2, 3, 4, 5. Technically, we're 1 over quorum, so that's okay. Let's just do another quickie run. Enrique, have you joined us? Don't see him. Michelle Duberry, have you joined? Also not seeing Michelle. And Bonnie, have you joined? No sign of Bonnie. All right, and Tony's coming late. Robert? I have 6 out of 11, so Ali, I think we do have a quorum, unless you want to say something about that.
Enrique, hey, sorry, I was on the other invite, and Enrique was there and a couple of other people, so we might just want to reach out, give them a minute to come back.
Okay. I didn't realize there was 2 sets. This is the one that I got in the email.
I'll pop back over to that one and just clear it out and tell them to come to this one.
Yeah, thank you. All right. All right, let's hope up a minute. Should be okay. I didn't see 2 links. I don't know what the other link was. I didn't see 2 links. Well, anyhow, that's okay. Whatever.
I think it's that old link, Bill, from long ago.
From long ago.
Yeah, I
people
think
just
that's what it is.
pasted into a into a
Possibly.
repetitive thing.
Yeah.
Okay. Yeah, I don't use the Google Calendar, so I'm constantly updating with whatever you send with the latest stuff. All right, let's wait one more minute. And just rolling down the list here. Bonnie, is that you? I see a Bonnie unverified. She's clocking in.
Hello, everybody. It's Enrique. I'm in the real
Hi, Enrique.
link now.
Thanks. Yep. Thanks for getting updated there. All right, I got you, Enrique, loaded. I see Bonnie.
I'm here.
Bonnie.
Yeah.
I hear Bonnie now. All right, very good.
I couldn't get in quick enough, Bill. I don't know what the problem was.
I thought it was just the length of time it takes an electron to get from Pendleton out to here. Right?
All the way to Hermiston.
All the way to Hermiston, yeah. You got to come down the railroad tracks.
Yeah.
All right, Michelle, have you joined?
I'm here.
Thank you. All right. So Tony is waiting for Robert. Robert, have you joined? Yep, I see Robert.
I'm here.
Robert, are you there?
Yep.
All right.
Yes.
We're good. So we're just waiting on Tony. We got a full house. Tony coming late. Tony asked for a late excuse, accepted. Their school is reopening after a closure on their district. Had a closure due to a threat. I'm sure we all see this on the news going on right now, so it's not unknown. All right, let's go to agenda item 2. Welcome new board members. I'll join here with Ali. Let's start with first. Our replacement for Dr. Tom Siltabo is Dr. Andrea Laura, who comes to us from OHA and is a health system strategist for OHA. Dr. Laura, would you like to introduce yourself? Give us 30 seconds of your life in 30 seconds.
That's kind of short.
Yeah, I know.
Good afternoon. I'm really excited to be part of the board and I'm ready to learn. Thank you for this opportunity.
Okay. Our second new board member, or actually our second and third new board member, are from COSA. They're replacing our 2 superintendents who retired. Sue Ricky Smith and Bob Stewart retired. And our first one is Tony Mann, who comes to us from Rolala River. He's the one who's going to be slightly late. We'll introduce Tony when he joins us. And the second COSA superintendent is Misty Wharton from Nestucca. Misty, you want to give us a quick intro?
You bet. Hi there. It's nice to meet everyone. My name is Misty Wharton. I'm the superintendent at Nestucca Valley School District, which is on the coast in Tillamook County, between Lincoln City and Tillamook, all those little towns there. I've been at it for 8 years. I graduated from the high school here and I'm multi-generational within this community. So I'm excited to learn from everyone and thanks for having me.
Happy to have you on board. Thanks for representing. And again, for the 3 new members, obviously reach out to Ali or myself as you're coming up the learning curve. We'll be happy to have any kind of discussions with you that you have questions on. Ali, you want to say anything?
Yeah, it's just it's been a pleasure getting to know the new board members, and I know they were just confirmed by the Senate last week. And I think as any new or even a board member that's been around for a year or two, it takes a while to grasp all the terminology and meetings. And I'd ask that we try and limit the number of acronyms. We actually have a glossary of acronyms that I'm sending to the new board members, and I'll actually send that around to the full board because we're in continuous learning mode on the OEBB board, and I think it can feel a little overwhelming at first, but I think after a while things start to click in like anything new, and I'm just really excited. I think in talking to the new board members, they're all really excited and ready to contribute. So So I think, Bill, do we want to go around and introduce the board and then maybe staff and Mercer?
Sure. Actually, that's a good idea. Let's start with the board. I'll start. On camera, I'm Bill Grupp. I'm your board chair. This is my 8th year on the OEB board, and just doing my final year here as chair. And boy, it's been an honor serving on this board for as long as I have, and really love the work here. Let me just call it out. Let's go to Enrique.
Thank you, Bill. My name is Enrique Ferreira. I am the vice chair, and this is my 2.5 years on this board. I am an academic advisor at Clackamas Community College on full-time release, and I part of the labor group, Oregon Education Association, with 42,000 members across the state. And happy to be here. Great group of people, great staff, and great board. Welcome.
All right, let's go to Cheryl.
Good afternoon. My name is Cheryl Berger, Human Resources Director from Hood River County, coming to you as just a member. And this is my first, I started late last fall on the board, and so I'm excited to continue this adventure.
Michelle?
Hi, I'm Michelle Dewberry, and I think I joined the board 2 or maybe 3 years ago. And I work at Portland Community College, and I represent the members of the Portland Community College Federation of Faculty and Academic Professionals. Welcome.
Sally?
Hi, I'm Sally Derfeld. I'm the Classified Benefits Coordinator for Eugene School District 4J, and I joined the OEB board in March of this year, I believe. I think that's accurate. Correct me if I'm wrong.
Sounds about right. Okay, and then Bonnie.
I'm Bonnie Luisi, and I'm from Hermiston, Oregon. I represent the Hermiston School Board, so I'm on the School Board Associations, and I've been on there, I think this is my 5th year, going on 6th maybe.
Susan?
Welcome, new board members. I'm Susan Miller. I'm the Executive Director of the Oregon School Employees Association. It's been a great experience working with the board, and very eye-opening and wonderful people. So welcome, and I hope you enjoy it.
Thank you. And Robert?
Hey, I'm Robert Young. I honestly don't remember how long I've been on the OEB board, maybe 6, 7 years. It was after Bill. So I'm a staff person for the Oregon Education Association, and one of my best assignments has been on being on the OEB board. And we have some subgroups we're going to talk about. I strongly recommend getting involved in that, new board members, because you learn a lot by being on those subgroups.
All right, Ollie, I'll have you go through your staff, and then we'll have Kirsten go through the Mercer staff on the call.
Yeah, thank you, Bill. I think we'll just have, for now, just myself, then Damien, Cindy, and Margaret and Glenn. Ali Hassoun, Director of OEB, and also the Public Employees Benefit Board. And I've also been the interim director for OHA's, the Oregon Health Authority's Health Policy and Analytics Division for the last 2 years. And I can thankfully report we have hired a new director that starts in November. So I will be going back full-time to my day job, and very thankful for that. Damien?
Hi, Damien Brago, Deputy Director for both PEB and OEB. Cindy?
Hello, I'm Cindy Bowman. I'm the Director of Operations for OEB and PEB, and welcome to the board.
Who else is on the staff?
Margaret or Glenn?
Yeah, hello, this is Margaret, and then I'll tag Glenn next, and it looks like April is on as well. Welcome everyone. I'm Margaret Smith-Isa. I'm a part of the program development team with OEB and PEB. I have been with OEB and PEB for 17 years now, so it goes quickly, but lots of interesting work definitely done by both boards. And Robert mentioned the subgroups. I am do a lot of work staffing those and supporting those groups as well. So looking forward to having the opportunity to work with everyone. And I will pass it to Glenn Bailey next.
Sorry. Yeah, my name's Glenn Bailey. I'm also part of the program development staff like Margaret, and I have been with OEB since, since its beginning in 2008. And, you know, it's a wonderful role, very interesting and lots of variety. And one of my roles is to staff the COW, the Strategies on Evidence and Outcome Work Group, and you'll hear a bit more about that later in the meeting.
And Bill, we also have Rose Mann. Rose, do you want to introduce yourself? And Sharna Freehan. And April.
Hi.
Go ahead.
Hi, I'm Rose Mann. I'm the board policy coordinator. Anyway, I'm the one that sends you all your board packets and calendar invites. I've been with with OEB since I was fourth person hired. So I've been there from the beginning. So if you have any questions, I'm the person you ask. If you don't ask, I'll leave. Bye.
And Sharna?
Hi, thank you. I'll get on camera. This is Sharna Freehan, she, her, hers pronouns. I've worked for PEB and OEB in the capacity of a policy and program consultant, and my work is focused on the health equity work group, which you'll hear about more later. Welcome, glad to have you.
And then we have April Kelly. You hear April?
Hi. Thanks for forgetting about me, Ollie. I'm just kidding. I'm on the I know I'm right. I'm on the agenda like once a year, I think. So I'm April Kelly. I always forget my title. Hold on. Program Benefits and Services Coordinator. I'm also the rule coordinator, and I work with both PEB and OEB, and I've actually been with OEB since 2008 as well. And then PEB probably 5 or 6 years ago. So we're so excited to have you.
All right, that's staff. Yeah. All right, is that right?
Yeah.
Ollie, you good?
Yeah.
All right, I'll introduce Kirsten Stadlin, who's our lead person for our contractor consultant, which is Mercer. And Kirsten, if you introduce yourself and then some of your team.
Yes, of course. Hi, everybody. I'm Kirsten Stadlin, along with John Kessler. I co-lead the Mercer consulting team. John?
Welcome, board members. John Kessler, good to see you again. And I co-lead the Mercer team. I'll hand it off to Ian.
Hi, good afternoon. I'm Dr. Ian Chuang. I'm one of the physician partners, part of Mercer's specialty practice, and I support some of the initiatives and work effort on CL related to all things clinical and medical. So again, happy to be part of the board again and working with this new group. Thank you. Sarah?
Hi, I'm Sarah Drake. I'm a pharmacist by training, and I'm part of the Mercer RX specialty pharmacy practice, and I support OEB on all things related to pharmacy. And I can turn it over to Christy.
Hello, everybody. Christy Ewing. I'm also on our Mercer Well specialty practice, and I have the pleasure of supporting OEB in a couple areas on the CO clinical team, as well as within our health equity work group. As Sharna said, we'll share more about that later. So welcome to everybody today.
Anybody else from Mercer want to introduce themselves? Is that good? I'll point out that Ian and Sarah have the sad responsibility of having to respond to my emails every time I see something on PBS that looks really cool, right? So they have that job as well. Okay, so that is the teams. And why don't we press on if we're good, right? So we're done with that, Ollie, right?
Yep, we're good.
All right, so On to item 3, and April has conveniently stated quietly at the end that she is the rules coordinator, right? So that every time we have an update to our policies and rules, it has to go through legislation, and we have to go through the rulemaking policy that is legislated by the Oregon government, and she coordinates all that. So she presents to us preliminary rules, draft rules, and then final rule submissions, and comes and we do a vote on the board to make sure that we adopt these rules properly. So she has a rule change coming to us. So let's get started.
Perfect. Thank you so much for that introduction, Bill. No, just kidding. Again, I am, sorry, make sure. I am April Kelly. I'm the rules coordinator, and I think Linda stepped in for me back in June, and she brought these rules. These are our Division 40 enrollment rules. So it's kind of the bulk of our rules for OEB. But back in June, we did ask ask the board for approval to go through the rulemaking process. And so that was approved. And so we went through the rulemaking process. We filed with the Secretary of State. We sent out a notice to all of our interested parties. They were all posted in the Oregon Bulletin. We do all the things, or I do all the things, but I love it. And we did not receive any public comment. I did hold a rules hearing, and I think partly why we didn't receive any public comment is we really had a really good rules advisory committee convene prior to the rules going to you in June, and work some stuff out. So I think that's why we didn't receive any public comment. We don't normally receive public comment, however, I am always open to it. But at any rate, the public comment period did close July 31st. Again, we didn't receive any comments, and staff did review these after public comment, just to make sure that the changes are the changes that we see fit. And did you want me to go through? I know you've had these for a week or so. Did you want me to go through the changes?
Just a summary, if you
Just
don't
to
mind,
highlight
for the
it?
new
Perfect.
members. Yep.
Perfect. So in Division 40, a couple of the changes, and I should probably have had my reading glasses. We removed the Rosh rule on newborns and adopted children, which aligns with the way that Public Employee Benefit Board, or the PEB board, process works and their rules. And just what that means is that the coverage is automatic for the first 31 days, and then the member has to add the child on to continue coverage. It seems to be that that's industry standard, and with the implementation of the new benefit management system, we are trying to align some stuff. So that is a change in this rule. Let's see, we removed the 12-month waiting period on the dental plan. We're super excited about that. Staff is excited about that because we got all the phone calls and all the emails on that. But we went through the rule and we removed that. We did clean up some qualified status change language. You'll see as I go through the rules, I tend to clarify. We hone in on clarifying language in our rules. And so some stuff that's not really, it's not a big change, but it really is just kind of clarification. And then we did update the declination of coverage section. That includes to include the veteran coverage and also Indian Health Services. So a few years ago, we received information, or we received advice from our Department of Justice, our legal counsel, that we can include that. And so we hadn't gone through rulemaking really since then, outside of COVID. So we wanted to include this and then include Indian Health Services. And then we also just cleaned up that language a little bit on the advice of our legal counsel. And those are kind of the main points. Does anybody have any questions?
Just to repeat, this is the final
Yes.
approval, right? This is the final
Yeah.
step, right?
Yeah, so what I'm asking is the board for approval to file these with the Secretary of State's office, and then they will be permanent. And my plan is, my plan was to bring this to you at your September board meeting, but that was canceled. So
Sure.
I'm here, once these get approved by the board, then I will go ahead and I will file them today.
Yep.
Yeah, effective today.
All right, board members, questions?
I can make a motion, Bill, if you would like.
Yep, I don't see any hands up, so go for it.
All right. I moved for OEB board to adopt the Oregon Administrative Rule OAR's Division 40 enrollment as presented.
Okay.
Second.
I'll second.
I heard a
Robert.
female voice second. Who was that? Susan? Okay.
Susan Miller.
Yep. Okay, we'll go with Enrique and Susan. I'll roll call bottom up on this. Robert?
Aye.
Misty?
Aye.
Susan?
Aye.
Has Tony Mann joined us yet? I didn't look, sorry. Not yet. Okay, that's okay. Bonnie?
Aye.
Andrea?
Aye.
Sally?
Aye.
Michelle?
Aye.
Cheryl?
Aye.
Enrique?
Aye.
And chair votes for. Okay, you got it. April, good job.
Wonderful.
As
Thank
always.
you. I appreciate your time. Thank
problem.
you.
Thanks for coming. Okay, moving on. We are now at an OEB overview, slightly ahead of schedule. Kirsten, is everybody you need available?
Hi, Bill. We're ready to go.
Okay, as soon as the presentation pops, there it is. All right, let's roll on to item 4 then, OEB overview.
That's great. Thanks, Bill. So this afternoon, beginning with the OEB overview, you'll be introduced to some of OEB's defining characteristics, and we'll definitely be careful to watch out for acronyms and OEB jargon, because we know not only do we have several new board members here today, it's really exciting to see you guys. We've been waiting months to meet you, but also we've had summer break. So I know it's been a while since we've been talking about OEB. So maybe we'll spend a little bit of extra time during our presentations, just making sure that we understand all the terminology that we're using. As we go through these presentations, please raise your hand and ask questions as we go. We welcome any and all questions that you have. But if you're not comfortable doing that or think of things later, you can always email OHA staff also. I'm going to actually hand the presentation off to Ali, who is going to start by covering OEB's legislative history and some background, and then he'll pass it back to me.
Yeah, thanks, Kirsten. Let's see, next slide, please. There we go. Yeah, I wanted to go back in time a little bit and talk about OEB's origin. And I was one of the lucky ones, like a couple others on this meeting, that had the pleasure of starting up OEB. And, you know, it's funny because, you know, I think between myself and April and Linda and Rose, Glenn, I think we were the original probably 4 or 5 out of 6 that took OEB through the initial rulemaking process and had the pleasure of starting up the program and trying to figure out how we were going to make this all work. So, but even before that, back in the early 2000s, you know, I think school districts were really struggling with, as everyone else, with skyrocketing health insurance premiums. I think the average premiums for groups in Oregon doubled in the previous 10 years. So that was really a tremendous, I think that's when everybody kind of started noticing that health insurance was taking up a bigger and bigger chunk of the compensation pie for employers, public and private. Some school districts were experiencing 20 to 40% increases in a given year, especially the smaller and mid-sized ones, and were especially susceptible to really budget crippling increases based on high risk or high utilization years. So at the time, school districts were responsible for procuring their own benefits using broker or purchasing through an insurance trust. And there was a really wide variation statewide in the plan offerings and costs. So in came Senate Bill 426, that was in 2007. I think after a couple failed tries to get that, to get OEB created through the legislature. So Really, Senate Bill 426 was created to help stem the rising costs of insurance and protect benefits for school employees. And it was really considered innovative at the time, and many states have followed OEB's lead over the years in creating large purchasing pools. We've talked to many different states, our OEB staff, and talked about the experience that we had. And I think, ultimately the goal in creating OEB was to give school districts of all size equal purchasing power and to leverage that purchasing power. I think you'll hear that word leverage several times today, and really across the entire state, and to procure for sustainable benefit program with some moderated cost increases year over year. We'll highlight that as well. Another key goal of Senate Bill 426 was to offer school districts and employees a choice of many high quality, high performing benefit plans. Focus was on innovation and, to really fulfill the requirements in Senate Bill 426, the board and staff had to be very innovative and figure out some really difficult puzzles. So it was estimated that OEB saved well over $100 million in premium costs, broker fees, and duplicative administrative costs over the first few years in existence. So that's been amplified over the 17 years now that OEB's been around. So in 2024, OEB has never been in a stronger financial position, which you'll hear more about in detail at the retreat next month. Also, OEB's purchasing power has never been stronger when adding in all the 16 community colleges who voluntarily came to OEB and several local governments, which continues to grow every year. And I'll talk a little bit more about that. Next slide, please. So, as I mentioned on the previous slide, a major tenet of Senate Bill 426 was to provide OEB's members with a broad choice of high-quality health plans. The initial OEB board set out on a mission to also prioritize a competitive marketplace, vying for OEB's business, bringing transparency to plan performance and data, providing school districts with flexible plan options to support their contracting needs, and also promoting value of OEB benefits as a key part of employee compensation. And lastly, providing world-class customer service, creativity, and again, innovation, and a focused investment on improving employees' health and wellness. Next slide, please. So as you see on this slide, OEB's vision aligns with its mission from the previous slide, and ultimately bringing a more collaborative and innovative approach in benefit design and administration. I think there was maybe one other state that had put together a statewide large group plan with all school districts included at the time. You'll notice this collaboration with our insurance carrier partners, the board, OEB staff, and our participating employers, and also our members. I think that's been a big part of OEB's success, is just the collaboration across all those groups. And really, when an issue is brought forward to the board, I think all these factions of OEB work together to address the issue. We always encourage board members, when they hear from members who are experiencing an issue, to come provide public comment to the board, or they can provide that in written form. I think that's a very, very effective way of getting the board to take action, to hear it front and center, and to address it front and center. I think this collaborative environment is very unique among large group plans, and I think that brings us to the next slide, which is highlighting OEB's unique value. So most of what I've been talking about on OEB is captured on this slide. All of these factors contribute to OEB's unique value and really reinforce the purpose for creating OEB in the first place. There is greater purchasing power. Annual budgets can be set with some confidence on the 3.4% per year. There's transparency and streamlined customer service. OEB has a seat at the table in conversations that drive statewide healthcare policy setting. And OEB now has well over 10 years under its belt. And it's really experienced some growing pains at first, but it's now considered a mature large group health plan. And I think its unique value has attracted over 2,300 new employees from 9 new educational and local government entities just in the last 2 years alone. And many more are calling and interested in joining OEB. I think that's a real testament to the work that the OEB board has put in. And looking over to this next slide, please, which is OEB's composition. I think the composition of OEB continues on a real upward trajectory. Again, I think that's a real message to districts, special districts, local governments, that there's something really special going on here. And I think more and more people are taking notice and wanting to get into OEB. And I think, again, that's a real testament to the board. And I'll hand it back over to Kirsten if there's no questions. I'm happy to take any questions.
Thanks for the background, Ollie. Let's go to the next. Let's go to the next slide and maybe one more ahead. Every year we present an open enrollment presentation, and the data that you'll see now is actually from last year's open enrollment. So it reflects employee decisions around enrollment as of 10/1/2023. We'll actually have updated open enrollment data for the 10/1/2024 plan year here at the end of October. And we'll bring the open enrollment update to you hopefully in December. So for now, just know that this reflects the 10/1/24 plan year. So we wanted to just give an overview of OEB's enrollment, who's enrolling in OEB and where are they? How do we think about enrollment, and how are we going to look at OEB's enrollment as we start to talk about strategy at the retreat? As of October of 2023, there were 254 participating entities. And Ollie mentioned that we've had some growth and we'll have some growth again this year as well. And we'll expect that total to be at 258 entities. And we mentioned that because we talk about OEB as if it's one big group. And in many ways, purchasing power, for example, in many ways it is one big group. But also, we're also simultaneously thinking about each of the individual 258 entities that purchase insurance through OEB and what are their needs, because we know not every entity is the same. For enrollment, those entities represent about 70,000 eligible employees out of Oregon's a little bit more than 4 million Oregonians. And then we have 56,000 employees enrolling in medical. So some people choose to opt out or waive coverage each year. As Ollie mentioned, one of the missions of OEB was to give employees a choice of insurance coverage. And this is one area where OEB, one of the many areas where OEB really excels. And we actually offer a choice of up to 11 medical plans. It depends a little bit on whether or not you're in the Kaiser service area and also what your school district has chosen to do. But there are 11 medical plans available through MODA and Kaiser, 7 dental plans, and 6 vision plans. OEB is a statewide entity, so we have school districts all over the state of Oregon. Some of them have a handful of employees enrolling in OEB. Some of them have thousands of employees enrolling in OEB. We think of OEB as being about 75% urban. Urban, we define, loosely as the I-5 corridor plus some of the more populated coastal areas and Bend. And then about 25% rural, which is the rest of Oregon, northeast, southeast, and then parts of the southwest and northwest. And then OEB has a very small portion of its membership out of state. These are maybe college age dependents, for example. Next slide. So of the 254 entities, what really stands out to me with this is that 33% of those entities would actually qualify as small groups in the small group market. and would really miss out on a lot of the features that OEB provides in terms of quality and financial protections and choice of plans. If we think about also entities that have between 51 and 100 and then up to 500 eligible employees, 85% of the entities, so the vast majority of them, have fewer than 500 employees, and we have a handful of very large districts. The largest one has 5,300 eligible employees. Next slide. And actually, we'll skip the next slide. It's the same view, but just looking at enrolled employees. So here's a picture of OEB, and we've divided OEB up into something called OEB Healthcare Region. And this is, region is just something that we've developed over time as a way of looking at OEB's population in more detail. So one choice might be, let's look at OEB as one giant group, or we could look at each individual entity, but we know some of those are small. So we group the entities into these OEB healthcare regions because maybe the entities in those areas have common challenges. For example, access could be one challenge facing entities in Southeast rural Oregon. So from here, we can see the coastal area, 6% of OEB enrollment, the metro area, 38%, the Willamette Valley encompassing Salem and Eugene, for example, 16,000 employees, about 29%, Southern Oregon, 11%, and then the Northeast at 5%, the Southeast at 2%, and then Bend at 7%. So we have enrollment all throughout the state of Oregon. It's certainly something that we're going to revisit repeatedly throughout the year, beginning at the retreat, as we talk about meeting the needs of our rural OEB members and our urban OEB members. Next slide. As Ollie mentioned, for many reasons, macroeconomic factors like inflation and rising healthcare costs is a major one of those. Employees have been joining OEB, and we've had enrollment growth. Last year, we had 2.2% medical growth, 3.2% dental growth, and 3.7% vision enrollment growth. We don't know yet how our enrollment is going to change because we don't have the open enrollment data yet for 10/1/2024. But we do know that if we're just looking at the entities participating in OEB, we have 4 new entities joining OEB. So at least on the entity side, we have growth again. And it's not surprising to us. John Kessler is going to talk to you more in the renewal presentation about the 3.4% renewal cap and how it compares to the commercial market. And it's definitely one of OEB's key values compared to the commercial market is that purchasing power and financial savings. Next slide. Ollie also mentioned the choice of plans. So we have 11 medical, 7 dental, and 6 vision. If you're in the Kaiser service area, an entity could potentially offer all 11 to its employees. And the Kaiser service area roughly overlaps with the metro area, plus or minus a little bit of difference from that. And then if you are in a rural area outside the Kaiser service area, then you are eligible for MODAS plans, which are statewide. And there are 7 of those. And in this later on in the OEB binder, for your reference, we have some slides with benefit highlights about all of these different lines of coverage. So you could see what the deductible range and out-of-pocket range is. But the takeaway from this slide and from the open enrollment data when we look at it is that employees really value choice. The entities value choice and that they offer many plans to their employees. And the employees also value choice in that they enroll in a broad range of plans. Next slide. In the December 2022 retreat, which was Mercer's first retreat with the OEB board, we spent the first part of the day setting new OEB board goals for the 23-24 and 24-25 plan years. And these goals were shift left, which means catch and treat disease earlier, also prevent disease, member education, quality and efficiency, and 3.4% renewal cap. We'll talk about those just a little bit more, but I wanted to circle back and invite Teresa Cross, who is OEB's Wellness Coordinator, to give a brief introduction as well, and then we'll keep going. Teresa?
Hi, everyone. Thanks for letting me pop in and just introduce myself. I'm the PEB and OEB Wellness Manager, and I've been working with Kirsten and her team and some other OEB staff to help implement that shift left strategy with the OEB Wellness Champions that are sprinkled throughout the entities in the state. So glad to be here. Thanks, Kirsten.
Yeah, thanks, Teresa. Great, so that we have on this slide and the next slide also, we've organized the major renewal actions that the board took by OEB board goal, because we really, to think about how we structure our year and the logistics of the OEB board, the work we do is primarily geared around the renewal. And the renewal follows the strategy, and the strategy is really defined by these OEB board goals and how the board wants to go about achieving its goals. Shift left was an idea. It's a term that was coined, I think, actually by you, Bill, and encompasses the idea we have a continuum from wellness and disease prevention on the left, all the way to the right, which might be acute condition treatment. We want to shift left and focus on prevention and early detection and wellness. Member education, again, is this idea that you could have the best benefits in the world, but if your members don't know about them or how to access them, then they're not receiving the full value of those benefits. Quality and efficiency, I just wanted to define the term efficiency for our new board members quickly. Efficiency is an idea of value, which says we want to provide the best quality provider, also at the best price. So it brings into this idea of quality a sense of financial value. And then 3.4% cap it's a legislative mandate from Senate Bill 1067 that our renewal increases are at 3.4% or less. Certainly that helps with entity budgeting. It also is a little bit symbolic for us as well, and represents this idea of affordability and achieving 3.4%, always with the effort of avoiding benefit changes or any other takeaways for our members. During the 23-24 renewal, we focused a lot on cardiometabolic disease, which we focused again, of course, on 24-25 and added some more support there. Kaiser made some delivery system updates that leveraged technology. And then there were some other small benefit changes to expand benefits. On the next slide, for the 24-25 renewal, we continued bringing more options focused on wellness and prevention and cardiometabolic disease by adding Mighty and Omada for weight management. We also worked closely with OHA, who was a pioneer in the doula services. So a doula is someone who helps assist birthing parents pre and during delivery, and also can provide post-delivery support and helps improve outcomes both for the parent and the baby. We added Gabby, a breast cancer early detection and education solution, and enhanced dental benefits for members with developmental disabilities. So this coming November, in our in-person retreat, we'll be looking at some new clinical data and talking about what do we want to do for our OEB members in the 25-26 plan year. We always work so far in advance to help continue to shift left. Next slide. This is just more for your reference, and John will touch on this more, the structure of the renewal process. So in the interest of time, let's go to the next one. We'll let John handle this. Yeah, and one more. Another way that OEB is so unique and provides value compared to the commercial market is that joining OEB comes with a deep bench of expertise. For example, you, the board members, although some of you might not feel like experts yet, you will be by the end of this renewal season. We have 4 committees serving OEB, the CIAO committee, the Health Equity Committee, the Innovation Work Group, and then of course also we know the OEB Advisory Group provides valuable insight. And then underneath all of it is this layer of really strong foundational support. Of course, you have OHA leadership and staff who you met today, also Mercer consultants, you met us today as well, and then many carrier and vendor partners who you'll have the opportunity to meet throughout the year. Robert Young, thank you so much for calling out. We have some open seats on some of these committees, and it's a really fun opportunity to get to know OEB better and also to get to meet your fellow board members and other OEB partners. Next slide. So we have one slide that introduces the CIAL committee, and then one for the Health Equity Committee and one for Innovation Work Group. Ian, Christy, and John are just going to walk you through those 3 slides. Go ahead, Ian.
Thank you, Kirsten. Yeah, so, CIAL is the Strategies on Evidence and Outcomes Work Group, and it's one that is supporting the board in achieving their goals. And there's various board representation, of course, and then Mercer, we bring sort of some of our clinical expertise in the form of myself or Sarah or Christy to support this work group. And this work group kind of has 2 focuses as described here. One is the clinical oversight. As programs are in place during the plan year, we're trying to leverage and work with our carrier partners and their point solution contracts and subcontractors to assess and look at the outcomes that we are expecting, right? So ultimately, are these things that we are put in place achieving the goals and outcomes that we expect? And that's through looking at the data and getting the reports from our partners. And then we're sort of applying what would look like a continuous process optimization approach, right? Understanding where the needs are and the opportunities, collectively working together to strategize and communicating some of those strategies outward. The second one is more strategic in the sense that some of us are bringing external insights, exposures to other innovations that may be out there in the marketplace, or things like Bill will ask and bring up, and then we will research that and formulate a recommendation and a position around that, have that discussion with the CIAL, obviously always with the intent of, is this going to be advantageous? Will this address the need that the members in OEB would value and benefit from versus what is the science behind these approaches? How credible are they? How effective? And will they be efficient in delivering the value that we expect? And all those data points sort of come together into recommendations that the CIAL makes back to the OEB board. So very interesting work group. So a little promo here to always recruit interested participants. But this is where, the thought leadership and we touch on innovation versus what's happening through the plan and try to mirror them together and make proposals and recommendations moving forward. Next.
Great, thanks,
Christy?
Ian. Hi again, I'm Christy Ewing, and the Health Equity Committee is supporting OEB's board's decision-making process with health equity considerations. And we really bring forward, the member and the entity's voices and really providing benefits, programs, and resources that are taking into consideration the needs of all members. And so we do that in kind of 2 different areas. First of all, looking at health equity strategy, knowing that OHA has a commitment to their 2030 health equity goal, and then also within the OEB goals of prioritizing health equity within the programs, resources, and benefits that are being offered. And we do that in a couple of ways. And we have later today a more detailed presentation on the Health Equity Committee in our work group. So I don't want to steal any of that thunder for Sharna and I at a later time. But we also, when we do health equity considerations, we do have an evaluation process that we use when we're looking at programs and resources. We work collaboratively with the different groups, so the Innovation Work Group and the Strategies on Evidence and Outcomes Work Group. really to work collaboratively and look at different impacts and bring those to those projects that they're looking at. And then always we are here for you, the board, to provide considerations, to answer questions, to do deeper dives into areas that you have questions about or wondering what the impacts might be. And I also am going to do a plug for members, for board members. We do have 2 open positions. And, you know, this is an area that it's so important to have board members participating because, again, you are representing your members and entities. And so bringing forward those voices is such an important component of the Health Equity Committee and Work Group that we encourage you to join. And I'll pass on, I think, to John.
Yep. Good afternoon. So the Innovation Work Group supports the board in achieving its goals by assessing and recommending to the boards various forward-looking and innovative items. And these items generally fall into these 2 categories that you see here around payment reform. You know, so again, one of the goals here is to advance the value-based payments. And looking at centers of excellence, and centers of excellence is really a concept where, you know, for high cost procedures like hip and knee replacements, that you're channeling utilization to those providers who have the best outcomes. And then the reviewing of the network contracting, that's really kind of key. So the thing is, as part of SB 1067, which was kind of key in introducing the 3.4% cap, along with that, the legislature gave a tool to help meet that cap, which was really making sure that hospitals don't that hospitals adhere to a payment cap of 200% of Medicare. So again, you know, that's something that is done by the Innovation Work Group. In addition, you know, in terms of plan-wide efficiencies, I think some of the key things there are really, one of the key things is around the performance guarantees. A lot of these things kind of get grouped together, that performance guarantees help to improve the member experience. They also help to promote the standards of care. And these are, you know, there's a common set. I think one of the strengths of IWG is really that there's a common set of performance standards across all of the carriers. And these get, you know, so the IWG is looking at those results, both the clinical and the service results each year. And, you know, as there's a need, you know, negotiating, you know, new performance guarantees where there are performance issues with the plans and such. So that gives us kind of a high level view of what IWG does. And really, you know, it's key to the board in terms of bringing, you know, advancing, you know, things in terms of payment and advancing, you know, the care that patients are receiving and the experience that they have.
Thanks, John.
Okay.
Next slide.
Yeah.
And let's go, I think 2 more. Right, we wanted to end on a note about collaboration. Seems fitting for today and meeting our new board members. But also, we just wanted to highlight that, you know, OHA, the Oregon Health Authority, of course, is a state agency that administers the OEB, PEB, and Medicaid programs. And combined, OEB, PEB, and Medicaid account for 38% of the population of the state of Oregon. So even though we are OEB and we make decisions that are based on the needs of our OEB membership, we, of course, don't exist within a silo. And to the extent that we have shared goals and priorities and are working on shared initiatives with PEB and Medicaid, it makes sense to work together and learn together and leverage our combined expertise and effort. And we have a couple of examples, I think, on the next slide. Yeah, one more, please. Of some recent topics that we've been working on either with OHA and or PEB. So for example, Medicaid, the Oregon Health Plan, actually pioneered the doula benefit, which again helps improve maternity outcomes. And we worked closely and want to call out a big thank you to Lily Sintum at OHA for sharing her expertise and learnings with us so that we could start there and roll out a new doula benefit for this coming plan year, 10/1/2024. We also partnered with PEB to study the feasibility of GLP-1 drug coverage, which is something also that the Medicaid pharmacy team worked on to make sure that we have a smooth rollout of House Bill 2002, which protects gender affirming care services. And then we've been working over the summer again to leverage work in the Medicaid space around a group of providers called traditional health workers to see if we can improve outcomes and expand access to important care for OEB and PEB members by tapping into this broad base of providers. Great, so thank you very much. And I'm going to pass it off to John.
Thank you. Next slide, please. Next.
Can I pause for a
One
second,
more.
John?
Yeah,
just for a
please go
second.
ahead, Bill.
This is kind of an in-between point where we just take any questions on the OEB overview from board members on how OEB is, what's OEB history, how we're setting our goals, how we achieve our mission statement. Anybody from the board want to make a comment or a question before we get into the renewal work that we do every year? I don't see any hands. Okay, John, I just wanted to give the floor a chance there for a moment. Let's move on.
No, thanks, Bill. I think that's a really good idea. And again, we're open to questions as we go along. So again, the other than going out to bid, the renewals are really the primary tool that the board has to execute its strategy. And that, so I think that that's what we're bringing to you today and really kind of taking you through the process of the coming months. So beginning in November, that is when the board will be establishing its goals for the coming year. And that will be part of the retreat. So a large part of that retreat will be about revisiting the goals and setting goals, longer term goals, and also goals, specific goals for the renewal. And then in early December, after the board meeting in early December, the renewal request letters are sent out to the carriers, and they have a few weeks to complete their responses. And typically we'll receive their responses either late December or early January. And that's the round one, which is really kind of kicking off. So, and then we use the month of January is usually spent by both staff and Mercer analyzing those responses and preparing for the reviewing those responses with the board in the February. So in February, we have that first round of responses. And these include both benefit changes and also program changes. And then we get feedback from the board on the round one results. And using that feedback, we come around, round two goes out pretty much the end of the week of that board meeting in February. So then that's the round two requests go out. We receive those a couple weeks later. And again, a big thanks to the carrier partners, because we understand this is a challenging schedule, but it's key to be able to meet the open enrollment and other deadlines and contracting deadlines. So we really appreciate the efforts by the carriers to kind of get on this kind of treadmill with us as we go through the renewals. So the round two responses are presented in the March board meeting. It's kind of the same process as in February. There's feedback from the board, and that is incorporated, and those go out, pretty much the end of that week of that meeting in March. And then we get to the round three responses, and those are presented in the April board meeting. And the April board meeting is really key, and that's oftentimes held in person because that's where a lot of the decision making takes place. And a lot of the decision making, kind of falls into the decision making falls into two categories. One is really around are there benefit changes or other decisions that have to be made, perhaps using reserves or what have you to get to the 3.4%. And then the other piece is really what, program changes, particularly in the clinical area, does the board want to proceed with, to improve and enhance the health of the OEB members going forward. So, and again, these approvals have to be in April just to allow time for all the prep that goes into open enrollment and also the contracting that follows that. So let me just pause there again. The purpose of this slide is to give you an overview of the whole process, and then we'll kind of take a deeper dive into each of the pieces. Okay, let's take that deeper dive. So as Kirsten had mentioned, in 2022, the board set goals for both the coming year, those two plan years. So it'd be the 23-24 and the 24-25 plan years. And it's really time, 2 years into that, it's really time to revisit those. So that will be, part of the retreat will be to revisit those goals that were set 2 years ago. And the goals, you can see the list of the goals could exist in the following areas, clinical benefits, financial, health equity, service and member experience, and others. So this is part of the discussion that we'll have in the retreat next month. And there'll be a little bit more on the agenda for that retreat coming up towards the end of our presentation. Next slide. So I think, and we've just introduced you to all these different work groups. So that's, CAL, the Health Equity, and IWG. And, they're very helpful in this renewal process too. And what they do is really help the board in terms of the heavy lift of making these decisions. So what they all have their areas of expertise, as we just discussed, and essentially the work groups, come back with recommendations to the board, on the various changes that are being made. So if there are benefit changes being made, or if there are clinical changes being made, so the clinical changes typically will come through recommendations from CAL. In terms of the benefit changes, we would expect some feedback from the Health Equity Committee, to better understand what some of those implications might be of those benefit changes and things such as that. So again, this is a collaborative process between the work groups, and the work groups are there to make recommendations to the board, and the board makes the decisions. So that's really the process there. Any questions? And I noticed something came in chat. I just want to make sure it. Oh, so in terms of the good question. So the thing is, the goals that were set 2 years ago were the ones that Kirsten went through. So they're in this presentation, and we went through them earlier. So hopefully Cheryl, does that address your request?
Yes, thank you. I apologize if I didn't realize that was made clear before. So I'll go back and review to ensure that I understand. I just was thinking, as we prepare for setting new goals, it would be good to have the takeoff point.
Absolutely. And no apologies necessary. I mean, there's a lot. I can't even imagine being in your shoes and trying to consume all this information. It's like, I've been doing this for many years, and it's a lot to consume. So definitely appreciate the learning curve here.
Thank you so much.
Okay, so I think that covers this slide. Any questions? Okay, so then this is really, I know we talked about this, so I won't go into too much more here, but the challenge, we talked about the really almost the process here of the different rounds. And what I want to kind of touch upon here is what changes in the different rounds. So the thing is, between one round, the first round and the second round, what we'll typically do is, Kirsten and her financial team will we'll have negotiations. There's also updated experience. So the thing is, additional claims will come in, and that will be incorporated into the renewals. And hopefully that claims experience has gotten better, so the renewals will go down. So those are the types of things that happen between round one and round two. So we have the additional experience, and the other thing too is that that's when we're also trying to figure out how to achieve the 3.4% cap. So the thing is, typically, Mercer will come up with some options for the board to consider. Some of those might be plan design changes. It might be also a combination of plan design changes and use of reserves. So it's really providing some information to the board. And again, this is just in case the renewals are coming in above that 3.4% cap. If they're not, there's no need to go through that process. We did have to go through that process during the last renewal cycle, with Kaiser, and it was a mix of plan design changes that you can see later in this presentation, and use of reserves. Let's see if there's anything else I want to highlight here. I think the other thing too that you're seeing, and this comes into April. So when we come into April, we're also not only making benefit decisions, but also making those program decisions, particularly in the clinical areas, and really having to approve those changes so we can move forward with the rates. And then the rates are confirmed, with the carriers, and then then we're off to the races to get to open enrollment. And open enrollment occurs generally for most entities between the middle of August and the middle of September. So there's a fairly heavy lift after April to kind of get ready for all those things and all the open enrollment communications and things such as that. I think we're good on that slide if there are any questions. Okay, so here are the carriers, and you can see, I think a couple things to note here that I think are interesting. So one is that both MODA and Kaiser offer medical, dental, and vision. And again, as noted earlier, Kaiser's service area is more, MODA is offered statewide, Kaiser is offered, their service area is generally the Portland metro area and the I-5 corridor. So that's where Kaiser is available. So in terms of medical, I think we've talked a little bit about this. So there are 11 plan options, which is quite sizable. And again, not every entity will necessarily offer those 11 plan options, because some of them are not in the Kaiser service area, and some of them, do not want to offer all of the options. So that's something. Oh, Sally, go ahead, please.
Yeah, you might not be the right person to ask, but with Kaiser, I'm in Eugene, right? There is Kaiser Dental here, but from what I understand, they have like one full-time dentist and one like quarter-time dentist. And so my wondering is if you're aware of if Kaiser will be expanding their dental here in this area. Because we haven't yet considered really looking at that, because for 4J we have over 2,500 employees, and so we offer Willamette Dental and Delta Dental, but it doesn't make sense for the cost to either replace or add Kaiser Dental just because of the limited amount of dentists that they have available.
Yeah, and we're not in a position to speak for Kaiser whether or not they're going to expand in the Eugene area, but that's certainly something that we can take away and bring back at the next meeting at the retreat.
Yeah, perfect. Thank you.
Yeah. And then we have, in dental, there's also Willamette, which is just a dental offering, and then also there's VSP, which is solely a vision offering. The standard, there's a host of programs underneath the standard that just want to highlight briefly. So they offer both short-term disability and long-term disability, and they have 3 different options of each. And some of those options they also offer employer paid, and they also offer the employee paid. So there are quite a few different plan options under the standard for disability. In addition to that, they also offer life. So there's employer paid basic life, and then they also offer employee paid voluntary life. That's both for the employee and their dependents. So there's a fair amount of other things there too. You know, UNM is here. You know, they offer long-term care. You know, again, that's more of an optional benefit. And the other thing I'd want to highlight is Canopy, which is new EAP. So welcome Canopy. Today is their first day effective date. So they went into place today as the new EAP. Any questions? Okay, let's move on to the next slide. So I think the key point of this slide is really just showing you which contracts are renewing versus which contracts are, you know, in a rate guarantee. So the thing is, as you can see from this, other than Canopy and the standard, you know, which are in rate guarantees, all of the plans will be renewing this year. Okay. So if we could just jump to slide 13 at this point. Because I think the key point, and I want to go back to something that Ali highlighted early in the presentation about the value that OEB brings, because I think that this slide really helps bring that home. And again, we understand that this slide doesn't necessarily address affordability because, you know, the employee contributions are set at the entity level. But what this does show is that shows that the, you know, from a budget perspective for the entities, what they're seeing. And it's a good picture. Oh, if we could just flip back to that one. Thank you. And again, you're seeing, you know, this is the effectiveness, one of the key things that OEB is bringing to the table. And you can see an average over the years shown here of under 3% compared to more than double that for the commercial market average. And so I think that this is really part of the value, especially over time, that, you know, might encourage more people, more entities to join OEB over time because of that controlling of you know, increases in trend over time. I think it, you know, for the next two slides, I think these are probably best covered in if we could just flip through them. But I think that these are best covered in the retreat and having Dr. Twang and Sarah address them. And then we can click through the other slides fairly quickly. So again, here's some highlights. We already talked about the offering of the 11 medical plans. I think the other thing to really highlight is really the different types of plans that are available here. And here, apologies for the acronym. So we have health maintenance organizations. And again, those are you know, more closed systems where you have to select a primary care physician. Then you have the preferred provider organizations, which are networks generally of community providers, and you have in and out of network benefits. And then you have HSA plans. So HSA is a type, you know, health savings account, which is a type of which is obviously a type of account that are, you know, generally connected to plans that are known as high deductible health plans. And I think this is really back to the value that OEB brings, especially to the smaller entities, is it would be very difficult for small entities to offer this, you know, this full range of the types of plans. And as you can see here, there's a broad range of benefit options available to, you know, in terms of deductibles and copays and coinsurances and out-of-pockets. There's a very large range. In terms of special features, we have, you know, free virtual visits. We also have reduced copays for certain chronic conditions, coverage for chiropractic, you know, and acupuncture care. And then starting in the coming year, there's through MODA, there's a 6 for 6, which is through Costco. And again, just note that even if you don't have a Costco membership, that's fine. You don't need to have a Costco membership to use the pharmacy there. Again, I think there's other things that we could go through here, but we won't. Again, on the far right, we have some highlights of some recent changes around trying to drive access, improve access through telehealth and things like that. We've talked about the doula. I think the other key thing to highlight is really Gabby, which is an online application that helps women better understand their breast cancer risk, which I think is critical because not everybody needs to follow the same guidelines. So that Gabby helps you understand what your risk is and really what your it customizes when you should be getting some of the screening for yourself. The other thing that's really worth highlighting around the medical is really the major programs implemented for this coming year to address cardiometabolic disease, specifically MIGHTY through AMADA for weight management through Kaiser are key things. And again, and we'll hear more of this obviously in the retreat, but GLP-1 drugs, again, this is not something that is currently covered, but it is something that will be revisited. And then also family building, which is also something that's not currently covered and is up for revisiting. So that's some of the highlights as we come into the new plan year, beginning today. This is just a matter of recording some of the benefit changes that occurred. As we noted, Kaiser came in above the 3.4%, and as a result of that, there was a package of plan design changes and use of reserves that was used to get them where they needed to be. Next. The dental, I think we highlighted some of these things. 7 plans through 3 different carriers. Both HMO and PPO style plans are available. Orthodontia is covered in most of the plans, which is a plus. There's some unique features to the Delta Dental plan where it encourages you to get the preventive care by increasing your benefit over the years, and also not accruing the preventive services to your annual out of the annual maximum. I think the notable highlights, I think one of the key things is really beginning this plan year, which is today, no dental waiting period. So that has been removed. And the other key thing is the removal of lifetime limits on implants for Kaiser too. And then you also have, and I think this is a good example of where the health equity committee really helps, is really these enhanced benefits for members with intellectual disabilities. This is something that they helped to highlight for us and something that we pursued during the renewal process. Next slide. Vision, 6 plans. Again, you can see a range of copays and things such as that. Both HMO and PPO type offerings. And I think there's not much more to say. In terms of vision benefits are typically somewhat more straightforward than medical. Next. I think we went through this, I tried to cover some of this when I was going through the carrier slide. I think it is worth highlighting some of the special features. So about a year ago, almost exactly, Paid Leave Oregon was implemented. And as a result of that, there were a lot of changes in the short-term disability plans last year to kind of coordinate with the implementation of Paid Leave Oregon. And I think that's one of the key things to highlight there. And I think we can keep moving just because Canopy, this is really a new offering beginning today, and pretty extensive coverage here. So you have 8 sessions per incident in terms of visits with a licensed counselor. You also have coaching is available to you, and then anonymous virtual peer support. And as you can see, there's a whole, and then a couple of things to highlight in terms of special features. Entities may purchase separate services as they need directly from Canopy. And then also Canopy brings a suite of digital tools, including their app, some self-scheduling, and then also digital cognitive behavioral therapy. And then also, I think you'll find a more collaborative approach to account management and supporting the entities. And then on the far right, just a list of additional offerings that are available through Canopy, what in their suite of what they call the resources for life. Okay, I think next slide, and that's it. So any questions? And then Bill, I'll turn it over to you. I don't know if you want to take the break now or how do you want to handle it?
Well, let's have a board chat for a little bit. That was a lot of information. Appreciate Mercer for the time in presenting all that summary and where we were, where we started from, how we got here the last 2 years. I'll relay some of my thoughts now. So for board members that are fresh or are new to the board, the way this kind of operates when we get into the January, February timeframe, or sorry, February, March timeframe, is we will start making trade-offs with estimates on where we are, and always remembering that we are legislatively capped at 3.4%. And as much as everyone on the board really wants to give everything we can to our members, you just can't. So you start making trade-offs. If you're on the board for me, like 8 years, you'll have 1 year where everything's coming in under and everything's great and you have a happy year. And then a worldwide pandemic hits the next year and everything you thought you knew is out the window and you're starting again, or there's a legislative change capping hospital cost to 200%, or there's all these things that are happening all the time that just say all your actuarial arrangements that you finally got in your head and you got it straight, and then it's all out the window and we're starting again. And then you come out of COVID and then suddenly GLP-1 drugs at $1,200 a month are in front of your face and everything you thought you knew is out the window again. So you're always making these trade-offs on things that are there. But what reason we have a consulting team here is negotiating the base rates for our board and then coming out with alternatives to do that. But in the end, you're kind of in a bind because every district or every entity, as they're saying in the slides here, is going to offer different plans. Not every district offers every plan. Districts will decide which plans they want to offer their memberships, how much they're going to cost share with their employees, and how that will benefit the employee. But what does come back to you is out-of-pocket expense. That is to the employee. That's where you're really trying to make good quality equity decisions for our membership, because that out-of-pocket expense, is part of the trade-off when you're trying to get more coverage or legally covering things that you need to cover. That's where the final trade-off comes in. It's with out-of-pocket max and the buy down. If we're going to try and use some of our reserves to buy down the rates to keep it to there, then you've got in your head all these equity things where, the superintendent doesn't have has a different concern package than the custodian. That's also in the same plan. So you have all these trade-offs that come in, and that's where we get into our great discussions in February and March. What do we want to swap out that will bring down the average cost, and then we can include other things. And so you're moving back and forth, and that's where the board work comes into play, where we spend a lot of time learning in December, January, February, and then we start making trades based on what we learned for that year and what's available. The concept that some people, I know it gets a little confusing because the numbers are coming by fast and furious when we get into the March, April timeframe, but numbers are coming in higher, like kind of strange, but in the end, it's the sum of all the numbers and the total cash flow that's going to come through the OEB board insurance plans that is 3.4%. So sometimes you'll see something going up 8%, but we're only at 3.5% on the total sum. So you have to keep in mind that this is an aggregate kind of thing where we're looking at individual processes, but they affect the aggregate in the total sum in a different way. And the math gets a little funky, but that is all done by our consultants and presented very well, in my opinion. And you will get choices. And so what they'll do is come up with 3 to 4 possible choices, and then we adjust those things like, well, okay, I'd like plan 3, but move this piece of plan 2 over to plan 3 and take something out of plan 3, and that's what we want. And then they go back, then our consultants go back and negotiate with the carriers and go with that. That's how the board inputs in trying to decide, how we're going to get to the final 3.4% cap by the time we're voting on it in May. So hopefully that adds a little clarity to the new members and maybe some of the members who've been around for a while. So opening the floor, I said my piece. Anybody else want to chime in here?
Bill, I thought that was a good summary, and I just I would just express my appreciation for both of the reviews. I thought they were really well done. They lead us up into a good position on the retreat, and especially with new board members coming on. I thought both of the presentations were really good summaries.
Yep.
Bill, this is Misty.
Yep.
And as a new member, I'm drinking from the fire hose, but I do feel like that was a really comprehensive overview that helped me out. So thank you, everyone.
Great. Anybody else have any comments or thoughts on the subject? All right, we are 15 minutes ahead of schedule. When we come back, let's come back at 10 minutes, and I'll open the floor because you'll have 10 minutes to think about it while you're grabbing a drink or whatever, or don't find any alcohol yet. Wait till the end of the meeting, and let's redo the floor in 10 minutes. So give it some thought. We'll come back at 2:40, open the floor for questions, and then restart the meeting right after that. How's that sound? Everybody okay with that? Okay, 2:40 it is. Thanks. All right, lost track of time there. All right, I'm going to assume that most people are back. Let us go ahead and say if anybody has any thoughts. The last two presentations kind of are the core of our 6 months of what we're pressing on with. Of course, a lot of details are yet to come, but this is kind of how the event goes. We repeat these steps every year, but every year it's completely different. I can tell you that. Ali, your hand is up. Go ahead.
Yeah, thanks, Bill. Yeah, just in onboarding with our new OEB board members, I'm offering some pre-meeting check-ins or post-meeting recaps. I think, that extends out to all board members. I think, a lot of times this material isn't the most straightforward and it's very complex. So we just throw that out there for any board member that's interested in just spending even just an extra 30 minutes of one-on-one time, I think would be beneficial. Thank you.
And the same for me. If anybody wants to have a chat with me about my experience, I'll up Ali's offer by adding either a picture or a Manhattan to the conversation. Right. All right. Anybody have any comments? Oh, something in the chat just appeared, or maybe it's been there. Oh no, thanks. Okay, never mind. It was there. Can't really see both at the same time. All right. I'm going to assume that everybody's back. Next on the agenda is a CIAL update, which is going to be done by me. We do have, I want to talk about where CIAL is, what it's a little bit of history, what its goals are, and then we have some proposed changes that we're going to consider, and we'll bring Glenn into the conversation at that time too. CIAL is a work group sanctioned by the board, along with the other work groups you saw in the earlier presentations. And that is something that goes on all the time. But let's talk about CIAL and the expectations of OEB and the CIAL work group. So basically, there's three primary stakeholders in what we do. This is Bill, the business manager now talking. So the first one and the key who we serve is the employee. But each of the stakeholders is interested in three main things: accessibility, affordability, and accountability. Those are the key metrics at a high level that we're always trying to do. But we look at it from each perspective of the three major stakeholder groups that we have. Of course, the employee is expecting accessibility and affordability, and they want great health care. The great health care that's accountable to quality, and delivery and timeliness. So we always have that in our heads that this is the actual end customer that we're serving. Next slide. The person in between us and that employee is the employer. Of course, the second major stakeholder. They're also interested in accessibility and affordability, and they want accountable benefits. They want to know that the money and the plans that they are choosing for their employees are delivering from an employee's point of view, as well as their financial point of view, that the employees are getting the best healthcare coverage, that the budget and that the system can allow it to happen. And that's what our role is in making sure that we give them those opportunities to get that affordability and accountability piece there. That is the employer. And then the third major group, next slide, please, is our vendors. The people who are actually delivering the healthcare. This would be MOTA, Kaiser, Delta Dental under MOTA, Willamette, VSP, things like that, and all of our contract employees for weight loss management, wellness management, mental health care, things like that nature. So those people are also trying to deliver accessibility, affordability, and accountability. And they want to be accountable for their outcomes, but they have to be reasonable in what they can deliver at the cost that we are striving to maintain. So those are kind of the key components of how we're viewing our work. Next slide, please. And what they come down to is that we take that affordability and we take the accessibility and utilization and we bring it all back to equity, that we are providing equity, equitable healthcare and quality healthcare to our constituents, in this case being the employees. Next slide. CAL brings this by being between the board and the clinical programs that deliver the message, not the primary programs like MODA and Kaiser, but the clinical ones that are really there, like would be Weight Watchers, would be the type 2 diabetes programs, would be the mental health care programs, things like that, where we are working with them as oversight. And the way I look at CL, and this is Bill's talk now, is we're doing the board work, but we're taking it to a much deeper level. We're getting into the details that we don't have time at the board, getting into that level of work where we're really understanding the metrics and the evidence being provided by the vendor, the clinical programs that we're contracting with, and looking at outcomes to see if they're really paying back for the value that we need, and then giving a recommendation back to our board saying, based on the detailed work that we have done at CL, this is our recommendations. Our look at this is kind of in a short term, maybe 1 to 3 years. What are we going to do for programs in the upcoming renewal in the year that we're in, versus also looking at a little further to predict what is coming our way in the next 2 to 3 years that will dramatically affect the work that we do, or could change our trajectory of what we want to look at for a longer term picture. But we don't do what, say, the innovation work group does, which is the big picture stuff like value-based payment plans, how integration works, how the larger picture with the major carriers is working, which would be and the word just went right out of my head, where you have a select set of vendors for high cost items. That is at the innovation work group. CL is doing a lot more detailed work in current clinicianal programs and their outcomes and evidence. Next slide, please. Okay, how do we support the board? We're doing clinical oversight for financial value, return on investment. We're driving engagement. We want to adjust those plans so that we can improve engagement from the members, and then look at how that engagement is practicing out. Did we achieve the goals that the plan oversight changes that were being prescribed? Did they do what they needed to do? Also, clinical strategies, which type of weight loss managements are doing good, which types are not, which types of diabetes programs, which type of cancer prevention, or not cancer prevention, but cancer treatment work and education are doing, things of that nature. We recommend clinical directions for the next renewal back to the board for board decision. Next slide. All right, our responsibilities are to review, select, and evaluate measurements for return on investment and quality, and things that we think are good directions. Like some things we may not have any data on, but through the analysis of the larger market and what is happening also at OHA, at the larger levels of OHA, which programs might we want to try? And we use some of our cash flow here to try and see if certain plans have better engagement than current plans. We evaluate proposed health benefits and program changes. That's our recommendations to the board. That's what our thing. We did this. We did have a work group for doulas and GLP-1s that were separate and associated with that, but then that evidence comes back to our boards for CL to look through and also evaluate from a data point of view. And we review performance of health improvement programs and initiatives to see if the work that we had done in the previous year or the previous 2 years is starting to pay back or showing evidence that the proposed idea is actually working. Next slide, sorry. History, see how group started when OEB was formed in 2008 to look at these more in depth, a smaller group of members of the board to go in depth to some of these plan suggestions, plan improvements, and plan metrics. In 2022, scope was expanded, right, to include healthcare programs. And also we brought in some PEB members from the PEB board to participate in CIAL, who were also interested in a lot of the data that CIAL was working on. Collaboration with PEB is always welcome. Because the more information and the more thoughts and the more minds we have, the better the outcome and the better the ideas. The diversity of ideas coming from a different set of employees is always beneficial when you're trying to make decisions on large group benefits. Next slide, please. Okay, so currently, and we're going to propose a change to this, but way it is now, currently we have 4 OEB board members. We lost our doctor, which is Tom Siltabo, to retirement, and we lost one of our general members, which was Sue Ricky Smith, who volunteered for the CIAL committee, and we have 2 PEB board members that attend our meetings as well. So staff is supported, and Mercer is providing us a lot of the data, as well as our key vendors. Mercer tends to collect most of that data for us, and then we go through the explanations, and the actuarial parts of that come from Mercer. The CIAL members will elect a chair. Currently, that's me. We will lead the meeting and just run it kind of like this. Our meetings, recommendations to the boards are basically a vote of CIAL members and to the PEB boards for specific projects as the PEB members decide on their own what is beneficial for them. We do meet 2 to 3 hours, 9 to 12, and we meet before this meeting. So if you're a CIAL member, you basically, your first Tuesday of the month is the entire day instead of the afternoon. We do CIAL in the morning, and we do the standard board meeting in the afternoon. That's how the scheduling works. So it's a full day commitment. Currently, to replace Dr. Siltabo, I have reached out and had a talk with Dr. Lara to be our medical professional on CIAL, and she has graciously agreed. Excuse me. Sorry. And so we will have Dr. Laura joining the CIAL board. To currently, then it's myself, Robert, and Dr. Laura. Wow, I'll take a moment. But we are making a proposed change with staff to the way CIAL operates. Next slide, please. All right, so our proposed changes are that we bring in PEB as an official member of CIAL and make CIAL a joint committee between PEB and OEB because the work that CIAL has been doing over the last, 20 years is beneficial, not 20 years, sorry, 15 years, is beneficial to both sides. And a lot of the data and the work that's being collected by staff and Mercer does benefit quite a bit to both things. The suggestion or the proposed change for CIAL is to make it a joint work group where we would have 3 OEB members and 3 PEB members, and deciding how to best do the work to benefit both boards. This, to me, is a good change. One of the things that would be important, though, is the independence of each of the 2 boards. Even though CIAL would become a joint work group, each group of 3 members from each board would independently recommend back to their home board on what it is. So there's not a requirement that OEB and PEB make the same decision. We are 2 different populations for sure. And more importantly, and for those of you on the OEB board, you don't see the PEB board. I do go to PEB meetings periodically. We have 2 completely different funding models. And so there are times where a decision or data will be viewed differently based on the different funding models between PEB and OEB, will come to different conclusions. And that is allowed in the proposed change that we're doing for CIAL. So the 3 OEB members will make a recommendation on work being done in CIAL to the OEB board, and the 3 PEB members will make an independent recommendation back to the PEB board. It may sound weird that that could possibly happen, that you're looking at medical data together and they're all serving human beings that all have medical, needs. But the reality is that when you have 2 different funding models and you have 2 very different populations, you can come to different conclusions. Not always rare, but it can happen. So that is will allow CIAL to become beneficial to both of our boards, as well as focusing and looking at what OHA the public plans are doing as well. Taking advantage of that scaling, where we're looking at work that can actually affect up to 300,000 bodies in the state of Oregon. Next slide, please. Oh, sorry, that's it. So for the CIAL team, if we do go ahead in November, we'll discuss it a little more at the retreat. And then in December, we have a proposed set from Glenn Bailey on updating the charter for CIAL to do these changes. It's basically this, what we just summarized for you. And then in December, we will vote for the change to make CIAL a joint work group, which should be beneficial to both boards then. Questions? So I know it says action item on today's agenda, but after some thought, we thought we should discuss this at the retreat and give it a little more time, especially for our new members, to absorb what's going on and how the OEB board works prior to asking you about a change like this. So we'll discuss it a bit, and we'll have questions and answer throughout the next 2 months, and we'll vote it on in a December board meeting. All right, opening the floor again for questions. Thoughts, comments? Boring? Also, it would be if we do go for these changes, the current CIAL membership would be Dr. Laura, myself, and Robert. That would be the 3. That we're the 3 that are currently on the CIAL team. I don't know if I mentioned that before or not. I forgot. Right.
So, Bill,
Yeah.
I'm supportive of this because the one of the biggest pieces on CIAL is just the dissemination of information, and to streamline that to both groups makes a lot of sense. As long as the each side can make their own decisions, I think it's a fine idea.
Yeah, we have a lot of commonality, and it's deeper than what they just do at the innovation work group, in my opinion, which is good work, what they're doing. But we need to be more detailed, more clinical, more evidence-based, in the near term stuff. Innovation work group does well for long-term, bigger picture things, and that's their forte, right? Yeah, I agree. Other comments? And I appreciate our new member, Dr. Laura, for stepping up and being our medical professional to join the CIAL team for this work.
Well, I just wanted to say that was a great kind of overview of it, and as Bill pointed out, we have since for the past 2-3 years, we have been working with this. We've had 2 PEB members, and we have been working on medical quality measures jointly, as well as sponsoring and recommending for GLP-1s and doulas. And so it has worked very well. And there are many programs that do kind of cross over between our two programs. But as pointed out, there are differences within the board. The funding structures, could be different, clinical goals that would really benefit from that independence as well.
And for new board members, I just want you to know that not in today's meeting, although it's kind of different, that at every board meeting, the chair of CL gives a 5-minute review of what the morning meeting covered with the work that was being done. We always are every month we're updating the board on exactly what CL has been working on, where they stand, what the data is. We give a summary in every meeting of what we're doing. All right, seeing no hands raised, we can, I'm just looking for a hand. Okay, no hands. All right, let's go on to Christy Mercer and the Health Equity Work Group.
Thank you, Bill. Hello again, everybody. We're going to do the deeper dive that I promised earlier into the Health Equity Work Group. And Sharna Freehan and myself are going to tell you more about the Health Equity Work Group. And so, Sharna, I'm going to first turn it over to you.
All right, thank you, Christy. I'm going to be staying off camera for the sake of bandwidth. I had a little reconnection issue right after the break, so I will be talking to you. Could we please go to the next slide, Maggie? Thank you. All right, so this is kind of the basics of who is on this work group and how we work together. We serve the boards, so we have 2 representatives from each board. And right now, as Christy mentioned earlier, we have 2 vacancies. So we're very much looking forward to offering those positions and letting you know what we do, so that maybe you might decide that that's something you're interested in doing. Our executive leadership right now, Cindy Bowman, our Director of Operations, is our executive leadership. We have our wonderful consultants from Mercer who do so many things. I'm not going to read the slide to you. You've had a lot of information today. But one thing that is really important is that they track the priorities that you as the board decide are important to OEB for advancing health equity within your membership. And program staff, we're there all the time to answer questions. We coordinate with Mercer, and we're always available for you, the board members. All right, next one. All righty, so our role. So since this is OEB and you're probably not as deeply seated into Oregon Health Authority as we are, Oregon Health Authority has established a goal for the year 2030 to eliminate all health equities in the state. And with the strategic plan, there's 5 pillars, and the 5th pillar is an internal pillar, and our work is directly feeding into that 5th pillar. But health equity, the definition is that each person can reach their full health potential and well-being while not being disadvantaged by their identity or social circumstances. So that is there in the center of the slide, and that's the basis of all our work. And as you can see, we work to improve health outcomes. We look at our policies and operational decisions from that health equity lens. We look to enhance member experience, and I know that Christy's going to tell you some more specific things about what we've done to enhance the member experience with board blessing. And we also look at those cost impacts, especially for low-income members. Christy, would you like to give some more details?
Yeah, if we can move to the next slide, I'll dive in a little bit more. So as Sharna said, we wanted to provide a quick overview of the projects that our group completes. And so really evaluation of programs and benefit changes from a health equity perspective. We use a tool which we call the Health Equity Screening Tool. This was developed collaboratively within the work group, and it's really identifies key areas of health equity impacts, and it really provides a format for evaluation. We run through it as a group. We kind of, taking in a clinical perspective, a member's perspective, the staff, lived experience, all of that comes together as we really look at the health equity screening tool and start the evaluation process. And then once we kind of evaluate and we find opportunities and strengths of different programs or resources, benefits that we're applying with this tool, then we will provide to the board a considerations document that just basically highlights the findings of this evaluation that can be used then in the board's decision-making process. We also oftentimes will look at vendors and continue monitoring. So when we do these evaluations of different programs and resources, sometimes we'll find opportunities. And so we'll keep monitoring those opportunities and kind of monitoring progress, holding vendor partners accountable, and again, really trying to improve the member experience and have equitable healthcare for all members of OEB. We also, as we're coming up into the renewal season, this is where we do look at the proposals from the carriers. We identify the programs or benefit changes that could have a health equity impact. We do review them, we evaluate them, we ask lots of questions, and then as a group, we really have discussion about it. And then also, as positioned before, we do support CIAO and the Innovation Work Group in contributing to the different projects. And as Bill said, those clinical programs, we might evaluate one of those programs using the health equity screening tool, but then we'll also, look at projects that the IWG is doing. And then lastly, we really look at strategy. We do this, kind of participating in the retreat as far as listening and hearing what you all have for your priorities and set as your goals. Again, supporting whatever it is that you need to set that strategy and goals. And then ongoing, just really supporting, looking at different projects. Sharna did listening groups last year as well, again, to really capture that member voice, and then collaborating on best practices for equity and benefits. If we move to the next slide, please. So here's a snapshot of some of the work that we've done this past year. As I've said, we did lots of program evaluations, which you can see there on the left. And again, for each of those, we provide a consideration document back to the board, just kind of, again, highlighting what areas that we found could be potential health equity impacts. On the operationally, we really continue to monitor carrier and vendor opportunities to improve equity in areas. And these can be areas such as like provider diversity. Maybe we discovered in our evaluation that there was minimal languages available. And then also in outcomes reporting, wanting to have specific types of reporting so that we can really make sure that the benefit and resources is equitable. We also this year looked at Oregon's definition of culturally responsive care, how it's monitored within the state and by the carriers. With House Bill 2002 that's come up previous, an assessment was completed of gender affirming care coverage with each of the carriers and how it aligned with House Bill 2002. And we continue to monitor this with the carriers and the service delivery. And then lastly, on the right, as I said, during that renewal season, we do look at all of the renewals, go through, kind of highlight which benefits, resources, we need to bring to the group. And then one of our biggest accomplishments last year was working with CIAO collaboratively on the doula benefit recommendation. OEB board approved this benefit starting October 1st, and then PEB board approved the benefit starting 1/1 of 25. And again, I can't stress enough, this is where having our board members come and join. Sharna will share at some further slides kind of what that looks like for board members, but it is such an important component of our work group. If we go to the next slide, this is just showing some of the specific impacts with the renewals this last year. you know, we've covered a lot of these, but, you know, again, just showing how collaborative that we're working with CIAO and within these recommendations so that the board is getting a full picture, and just highlighting, you know, some of the positive health equity impacts that these programs made. If we go to the next slide. And so for Q4, we're going to continue our work. It's never a slow time for us. And so we are doing presentations like we're doing today for the boards, and also, as I said, supporting within the retreat. We have some projects continuing with IWG and CIAO that will continue supporting. We've been working on traditional healthcare coverage. This is in addition to the doula traditional healthcare type, so we'll continue that work to hopefully bring with CIAO, making some, you know, recommendation for that in the months to come, and again, renewal process. All right, and so I'm going to turn it now back over to Sharna to talk about what it means to be part of the health equity work group for board members.
Thank you, Christy. So as you can see on the slide, we have the board member responsibilities. We meet at a minimum quarterly, so it's not a monthly or a bi-weekly cadence. It's usually when we have compiled a lot of information to present and get decisions on. And so we do our best not to meet with board members more often than is necessary. But once in a while, those ad hoc meetings do come up, and you'll see an email come to you saying, oh, there's something that's a little more time sensitive, and so we need an opinion on this particular subject. We do, as you see, we share strategy and committee projects with you so that you're always informed, and that we ask for your guidance for upcoming projects, and just based on what is currently OEB board priority, what is up and present for the board, and what items do you need investigated or researched from a health equity standpoint. So we can go to the next slide, please. Oh, this is easy. So we welcome you, new board members, once again, and we look forward to your partnership. And just a reminder that we do have 2 openings, and we hope that you will be interested in joining us in this health equity journey. Thank you.
Thank you, Sharna. Any questions from board members or?
Quiet day.
It's a lot
All
of
right,
information.
I'll also chime in and say, and I'm hoping that you'll consider working with our equity committee. As you can see, there's a lot of parts moving here as in the OEB PEB world, trying to do the best we can for all the members. We are way early now, so I'm looking for Rachel McCarter.
Bill, there are a couple hands raised.
Oh, there are. Sorry. Oh, they were behind me. Never mind. I got it. Oh man, my screen is not right. Andrea.
Yeah, hi. I have a follow-up question regarding the equity work group. Christy, how diverse is your staff?
I'm sorry, Dr. Laura, can you repeat that again?
Yep. Really, when we focus on equity, also diversity is important. So I just wonder how diverse is your staff?
How diverse is the members of the work group?
Yep.
This is interesting. So this is a project that we've been working on for a while, is to collect the demographic of our group. I would say our work group has diversity within it, whether lived experience and different race, ethnicity, background, language, but some of those things also are not necessarily always seen. So that's kind of why we have had this project of discussing how to collect that information in a way that is anonymous and respectful. So we do have some diversity. We always invite more diversity. We want to capture as many diverse voices as we can, because that's such an important component of our work group.
Thank you.
The other thing I would love to add to that is that one of our projects that we're working on right now is a way to connect with folks in PEB or OEB members that have lived experience so that we can draw on that expertise when we're looking at things from the health equity perspective. The idea, though, is to not create more burden on community when we ask for that expertise. So we're working on a way to ask for that respectfully, and we're looking at different aspects of how we engage those community members.
Bonnie, then Enrique.
I was just gonna say I'd be willing to serve on that committee if needed.
Thanks, Bonnie.
Yeah.
You can submit your resume and SAT scores, to Ollie. And
Well, you don't want my SAT scores. They won't take me.
Well, we would love to. I mean, I don't want to. I think your rural perspective too would be such a great component to have, and your guidance.
Cool, Enrique.
Thank you, Mr. Chair. I just want to add into the room that, for example, our chair leads the CL meeting. Anybody's welcome to join those meetings. So it's the same thing for the other committees. So you might not be a voting member, but you're able to sit there and listen and provide your perspective and feedback, depending on the time. But I've always been, I always felt welcome, So if you might not have the capacity to do it, but you do once in a while, because all of us are really busy individuals, I encourage people to drop into those committee meetings, and if you can be officially part of them. So that's all.
I'm not going to recommend this, but the first year I was on the board, I took the whole Tuesday off, even though I wasn't on CL, and I just sat in the CL meetings because that's where I did 90% of my learning. And then finally, Jeff Brown just said, "Dude, you're here all the time. Just come up to the table and participate with this." Right. So, but yeah, that was just, and again, I'm not saying that that's a recommendation, but there's a lot of details and things that are summarized at the board meeting due to time that you really learn a lot in CL. But, and again, if you ever just want to chat on the side about what we're doing, I'm always available when I'm in between. No hands up. All right, so what are we at? 3:18, and so still ahead. So coming back now, Rachel, or is Rachel available? Is she here?
Hi, Bill. For the trend guarantee settlement presentation, Ali is actually going to kick us off, and then I'll take over from Ali. Yeah, thank you.
All right, perfect. So let's roll on to the trend guarantee then. Oh, sorry, I'm reading the wrong line. My bad. I'm reading the next line. Can I stop for a minute though? Sorry, I gotta make a pause here because I realized over break, and then I forgot when we came back from break, that I need a motion and a vote to approve the minutes from our May meeting. I missed that at the very beginning of this meeting. So I'm going to open the floor, just a 2-minute pause for the board. Did everybody have a chance to review the minutes from the May meeting that were in the board packet? And are there any questions? And put it along. If there's not, I'll take a motion to approve the board minutes from the May meeting. Anybody want to make a motion? Do we still have enough board members on that?
Bill,
Yeah.
this is Cheryl Berger. I would make a motion that we would approve the minutes.
Okay,
I'll second
second.
that.
All right, I'm going to do this in a bulk fashion. All in favor, say aye.
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 All right, this is where we get to the count. Anybody opposed? Anybody abstaining? Perfect. So that passes unanimously. Thank you, everybody. Sorry, I realized I made a mistake and forgot that at the beginning of the agenda. All right. So now, trend guarantee, and this time I'm going to read straight. Kirsten, sorry, and Margaret and Ali, go for it.
Thanks. And I realized I'd misread my note from Ollie. So I think he debriefed some board members maybe ahead of time. So I'll just walk us through this presentation, and then Margaret, a member of OHA staff who's really integral in the innovation work group, which deals with performance guarantees. As you heard from John Kessler earlier, she's here also and can lend any historical perspective to. Hi, Margaret.
Oh, go ahead and finish your sentence, Kirsten.
No, I saw you pop up, so I wanted to turn it over to you.
Oh, thank you. Yeah. So just as by way of background, I think to set this agenda item up and to acknowledge, we are going to be asking for the board to make a motion related to this particular piece of information. And what you're going to hear, what Kirsten will delve into in terms of the data and the analysis, specifically relates to the OEB plan year that ran from October 1, 2022 to September 30th, 2023. And this relates to a specific performance guarantee that we have in OEB medical plan contracts. And under that performance guarantee, which was kind of developed and refined as part of the work of the innovation work group. What the guarantee requires is that, so every year OEB plans, when premium rates are determined, some portion of that premium rate is allocated, it's an administrative fee for the health plan. And this particular performance guarantee specifically applies to that administrative fee component. And carriers in their contracts agree to put 5% of that administrative fee at risk each plan year, with the goal being that cost trend for overall plan cost trend be maintained at 3.4%, in line with the statutory requirement on both OEB, and also this applies in PEB contracts as well, that plan costs stay within that 3.4% cost growth rate each year. Now, one caveat Kirsten will get into is that we do kind of tier the fees at risk. So there's 2.5% at risk if costs come in between 3.4 and 4.0%, and then if carrier costs come in above 4.0%, the full 5% performance guarantee applies. So it's just kind of background. This guarantee has been in health plan contracts for several years now. And so every year we come to the board to report out on the results, and there are some steps that we need to finalize and have board approval on related to settlement of fees at risk due. And so just with that background, thank you, Kirsten, for indulging me on that explanation. I'll hand it over to you to talk about the specifics of the results for this plan year.
Yeah, thanks so much, Margaret. That's really great context. And I think we can, if we go forward, we can actually skip over this mostly because you did such a great job introducing it. Maybe just a couple technical financial notes. So when Senate Bill 1067 was passed, of course, it did many things, and you've heard a lot of those mentioned multiple times today. And one of those was establish a limit on the renewal increase each year at 3.4%. And so that's a limit that we deal with every year when it comes time to approve the renewals and decide what programs we're going to offer. And unfortunately, sometimes have to consider, do we have to make any benefit changes to reach 3.4%? And you're going to get to go through all of that with us this coming February through April. But because we as OEB, and this applies to PEB as well, are held to 3.4%, this trend guarantee aligns incentives with our insurance carrier partners. so that they also have a financial incentive to manage the underlying claims costs, which are a huge aspect of the renewal increase, of course, also to 3.4%. And so this is a calculation that we do every year, and the exact mechanism is outlined in the contract, and it's a big collaboration and partnership between Mercer and OHA staff, the IWG, the Innovation Work Group, and our carrier partners as well. And so as Margaret went through, depending on how the results come in compared to 3.4%, some of that carrier's administrative fee might be owed back to OEB or PEB, and then it comes down to the board and the board's decision about what to do about that. So if we go forward a slide, so the results of this year, and again, something that's tricky about OEB is we have to think about so many plan years all at once. So this was the trend guarantee that was in place for the 2022 to 2023 plan year. And so we compared costs in 2021, 2022 to 2022, 23, and compared that cost increase to 3.4%. So that's the basis for this result here. So the result is that the measured increase exceeded the 3.4% to a degree where 5% of the administrative fees are now owed back to OEB, and that amount is shown here. It's really similar to last year. $685,000 for Kaiser Permanente, $1.9 million for MODA. And just for our new board members, there's a difference here because the enrollment in the Kaiser plans and the MODA plans are pretty different. Going from memory, we have maybe around 15,000 in the Kaiser plans and 42,000 in the MODA plans. So there's just a really big difference in the starting administrative fee, even though the 5% penalty is the same for both carriers. So the total amount owed back to OEB is $2.6 million. And last year, if you go forward one slide, please, there are two options for the board to consider, and we have an acronym here I want to define for you. It's something that we refer to as RSR, and it stands for Rate Stabilization Reserve, and it's a savings account that was initially seeded a few years ago with some of the surplus savings from Senate Bill 1067 when the hospital payment cap went into effect. And we've been slowly using that savings account to help meet the 3.4% each year. So this $2.6 million could be added to the RSR and used for future purposes. Sometimes we use that money to invest in clinical initiatives. Sometimes we use it for the renewal. Sometimes we don't use it at all. It could also be used as a credit to offset the upcoming 2025-26 plan year renewal. And that's actually what we did last year. And just to put it in perspective for you, this trend credit offsets the renewal increase about 0.25%, so 0.25%. Maybe that doesn't seem like a lot to you, but trust me, at the end of the day, when we are trying to get from 3.7 down to 3.5, down to 3.4, 0.25% goes a long way, especially when the alternative is benefit cuts. 0.25% of a premium increase helps avoid pretty substantial benefit changes as well. So that's a rundown. Please let us know if you have any questions. You can raise your hand, and Margaret and I or Bill or anybody else can answer, and then I'll maybe pass it back off to Bill to do the logistics of the board motion.
Yep. All right. I'm going to claim chair privilege and chime in here first. So with this concept, this is an incentive that is built into our carrier contracts to incentivize each carrier to control costs to the best of their ability. The debate we had last year, remember this was for the 2021-22, was a portion of that year we were just coming out of COVID. And as Dr. Siltabo argued intently, there was absolutely no way for our actuarials, results or predictions to predict what was going to happen. And what I'm going to say to you now is Bill's opinion. 22 is the first full year out of COVID restrictions. We had no real way of doing a good actuarial of doing the pent-up demand for medical services and how that would reflect in the first full year out of COVID. So as hard as everybody tried, and as hard as the calculators were banging out numbers, it was a difficult prediction to make. But if you look at the amounts here, they to me are in reasonable variation of what was unpredictable. Now, I don't recommend we eliminate this incentive. This incentive is a valid incentive for our carriers to control cost. However, in my opinion, the option 2 to, again, like we did last year, coming out of where we were partially in COVID, and then this year for the year that we were fully out of COVID, we use it to control costs. And we know that costs are going to be up, and we know there's some added benefits that we're going to want to have the carriers put into their plans this year that are going to probably take us over the limit. So for me, option 2, to use this fee as it was, by the reasons I just gave, to say that we need to offset the upcoming renewal with this cash, which is the way it will be to control costs for this coming year. There is a need for RSR as well, but for what we're using RSR for doing program trials and preliminary work, like first and second year costs to see if programs will work, there's coverage for that already. But this was something that is needed to bring down to control costs for the upcoming year, and putting that back into the vendor, because the vendor and our own teams, this was a difficult year to predict, the 2022-23 year coming, first full year out of COVID with unknown pent-up medical stuff. So that's my take on it, and I will look for hands. I've got my screen fixed so I can actually see hands. So we are going to take a discussion here, and if possible, a motion to decide what to do with this money. There's 2 options on the table from our thing. I'm recommending option 2 for this year, but the reason for that is, again, I think we need to keep this incentive for our carriers to do a good job in controlling costs and predicting how our rates will be for the upcoming years. But we also need to understand why they get into these situations and understand that and make a proper choice with the funds that are there. Questions, comments? Anybody say if I spoke proper English?
You did well.
I understood you.
Okay.
Perfect.
Even though it's not an action item, I will say that we will take a motion for the board to recommend, and we'll call it option 1 or option 2 on the slide that's in front of you, but then I'll rephrase it with the correct verbiage.
In the motion, you want this for November, Bill? You want this
now?
Now, okay. I move to you do the next steps as presented on the RSR and the offset of the coming renewal for the 22-23 credit use offset and the 25-26 renewal year.
So option 2 on the slide
Option
in front
2.
of you. Okay. Does anybody wish to second that motion?
Bill, this is Cheryl Berger. I would second that motion for option
Okay.
2.
Even though I asked before, technically, I'm open the floor for discussion. We have a motion and a second to use the administrative trend guarantee settlement money to offset the upcoming renewal for the 2025-2026 fiscal year. Discussion?
Hi, Bill. This is Susan.
Yes.
We did this last year, and I had an issue with it last year too. It just seems uncomfortable to me to say that we are going to tap into it or add to the RSR when we don't know what those renewals are in advance.
Well, we're doing option 2, so we're not going to add it to the RSR. We're going to contribute it to, or I see what you're saying. So you're just saying it the other way. So you're saying the same thing, but just understood. And that's a very valid statement, right?
Thanks.
For me, I'm just trying to recognize the the difficulty that the actuarial process had in this first year out of COVID is kind of tough to say, well, you get penalized when you just had something that no one could actually predict what was going to happen. But I'm actually surprised it got as close as it did, to be honest with you. Right. That's not going to be true coming up, moving forward. We're just still, getting everything back to normal post COVID, my opinion. But yeah, I respect that. You make a valid point. That's a very valid point.
Thank you. Yeah, I'm not saying we wouldn't do it. It's just uncomfortable to me to say that we would, not knowing the amounts. Thank you.
Understood. Yeah. This kind of helps sets the rates though when we go into negotiations in January. If we do it now, people can start preparing for it. That's my business side of me. Right. So any other discussion? All right, seeing none, I'm going to go top down on this vote since it's a money vote. Hold on, let me get my piece of paper here. Enrique.
Aye.
Cheryl.
Aye.
Michelle.
Aye.
Sally.
Aye.
Andrea.
Aye.
Bonnie.
Aye.
I never checked. Did Tony join us? I don't think so. I looked for him at break. Okay, I'm going to mark him as an A. All right, Susan.
Aye with reserves.
Sorry. You're voting nay to the motion. Is that what you're saying?
No, I just said aye, but with reserves.
Oh, I see. Oh, okay. When you said reserve, I thought you were like reserves account. Sorry, my bad. Misty.
Aye.
Robert.
Aye.
Chair votes for. Okay. Does that give Mercer what they need? You understand that discussion? Was the discussion good enough? Right. Ali, are you on board?
Yes, sir.
Okay.
Mr. Chair, I have maybe a comment.
Sure.
We had our discussion part of the motion, but I would like to raise Suzanne's concerns. So maybe we could have an agenda item in the next several meetings. How we can address that and moving forward, how we can, have the conversation of what can we do to improve this path.
Sure.
That'll be all.
Maybe a small agenda item to discuss how the actuarials, predictions for the cost spending, are being more understood, right? How
Yes.
about something like that, right?
That's correct.
As we're now into a model that we can flow along with. I agree with that. Is that what you're meaning? Yep. Okay.
Yes, sir.
Thanks. All right. Any other comments? All right. Now where I'm reading straight lines again, the Unum long-term care update with Rachel.
All right, best topic for last. So I'm here today to talk a little bit about some of the updates that are coming down the pike that will have member impacts from Unum on the long-term care side. For those of you that don't know what the long-term care plan is that are maybe new to the board, OEB does offer a long-term care plan that is a completely voluntary program that employees and members have the opportunity to participate in. This really is there to allow a financial safety net and barrier for employees that want to participate in a program to help cover some down the road costs associated with long-term care down into the future. So long-term care insurance really does help pay for facility benefits if you receive home health care benefits. This really does help offset those costs. So Unum has come to DCBS. We move on to the next slide. And because of some rate instability in the marketplace, we've seen a needed increase that is going to be requested by DCBS, and we expect them to approve that. That increase is going to be pretty large at about 110%. So significant member impact to those that are enrolled today. We have seen previous rate impacts requested from Unum and have been approved. It's been 6 years since we've seen any kind of rate increase passed along to members. But the previous increases that we saw between 2015 and 2018 were in the 15 to 20% range. So significantly less than what we're looking at here with the 110% rate increase. A couple of things that are causing the need for the 110% increase is that we have been in a traditionally low interest rate environment. We've had traditionally really low lapse rates within this program and high utilization. So when Unum is looking at their block of business, which this is rated holistically, it's not rated at an OEB type level. When they're looking across their book of business and looking at the rate increases that they need in order to sustain a level of profit to make this book of business make sense, that's where they really came up and they generated that 110% increase this year. Unum is the only traditional group long-term carrier in the marketplace, and they're the only remaining carrier in the marketplace today because of those reasons that I just highlighted, that a lot of carriers have pulled out of this marketplace because it has been traditionally unsustainable with the rates and the plans that have been out there. So Unum is really the only one that has maintained their position in the market. And the reason that they're able to maintain that is that they're continuously giving these larger rate increases in order to make their block of business more sustainable. So in terms of the number of enrolled members that will have an impact when this goes into place, about 465 members in total through the OEB population. That is those that are currently receiving this as a benefit through payroll deduction. There is a population that is receiving this on a direct bill basis. Maybe they've left employment and they've continued to keep that plan. There will be impacts there, but that's not really the responsibility of OEB to communicate and continue to take those payroll deductions. And at this point, DCBS is expected to pass along and approve this rate increase. And the date in which we expect this rate increase to go into effect will be October 1st of 2025. So we do have a year to plan and get communications out to members around what their options will look like. All right, so if we move on to the next slide, we'll talk a little bit about next steps. So the next steps is we expect the rate approval on the timing notice and acceptance from DCBS to be coming out tomorrow, I believe is the date that we're targeting. And then from a next steps perspective with Mercer and the OEB staff is we are going to work closely with DCBS to finalize that timing, the timing not only of the approval, but of the letters that are going out to inform members of those impacts. We also want to make sure that the communications around giving members options and what those options look like if they want to change their plans, if they want to renew as is and accept the increase, or if they want to drop those plans, what do those options look like? And are those clear? And do members have the opportunity to ask questions around clarification of what this means for them? So we're working behind the scenes a lot to make sure that this is a really good or as good of an employee experience as can be expected. And we will continue to keep the board apprised of those updates along the way. Right. From a timeline perspective, we have a question. Robert?
Yeah, sorry if I'm stepping out of turn here. So let's say I've been paying into Unum for 10 years, and I don't want to swallow the 110% increase. That just means I've just been giving money away for nothing at this point.
So you will receive a letter with options. So you're not going to have to terminate the policy. They're going to give you some options that are going to be very specific to you as a member. Your options are going to include things like if you want to continue to pay the premium that you're paying today, what kind of plan design changes can we make in order to keep your premium level? If you want to terminate the policy, they'll give you the value of that policy that's going to be a locked-in policy that you'll still be able to use. It's just not going to continue to grow. So you're going to have the paid up value of that would be available to you. And there will be several different options that will work through how that is going to be communicated to members, because we know 110% is not going to be something that everyone's going to want to take advantage of and swallow, right? So that will all be ironed out in those member communications in conjunction with Unum as we're talking through what those member impacts look like and what those options will be.
Thanks.
Welcome. Cheryl?
So thank you. Just a question. So you indicated, or at least I felt I heard you say that this is really the only option for long-term care within the state of Oregon. And so my question is if this option no longer exists, then are we looking at anything similar to what the state of Washington did when they have the CARES fund that went in for long-term services and it's mandated essentially?
So it's a great question. Oregon is a state among 17 others across the country that is looking at some level of long-term care legislation. I don't think it's very far along in the process, but it is indicated as a state that has it as an agenda item that at least someone has been batting around and thinking about. In terms of it being the only plan option available, today it is the only true group long-term care plan option available. There are other plans out in the marketplace that do offer a long-term care benefit. Most popularly, it's a life insurance program with a long-term care rider that's attached to it. So a permanent life plan that has long-term care benefits that are attached to that. And that is a recommendation that we'll get to and maybe think about, does the program with Unum, does it continue to make sense to support this, and continue offering it to members and continuing to keep that open to new enrollees, knowing that there are these continuous rate increases that are continuing to go into place? Or does it make sense to put on the roadmap, do we reevaluate what those other options are that are newer and more stable in the marketplace and think about bringing a new option forward to employees and members to participate in? Does that answer your question?
Yes, ma'am. Thank you.
Okay. All right, Susan, I see you have your hand up.
Yes, thank you. How many members, I know you said this originally and I missed it, but how many members did you say were enrolled in this now? And also, is this the same plan that PEB has, and are their members equally affected?
Yes, yes, and yes. So the rate increase from Unum is across all enrollees in the state of Oregon. So it's not specific to just OEB, and it's not even specific to just PEB. It's everyone who has a long-term care policy with Unum that has this simple inflation option. There's a lot of different options that are available. The option that OEB and PEB offers is getting the 110% increase. So unfortunately, everyone that is enrolled in that plan across the state is seeing the 110% increase. The number of impacted enrolls today on the OEB plan is 465 members, 403 employees, and then 62 enrolled spouses.
Thank you.
You're welcome. Okay, so we'll skip forward to the timeline just to give everyone kind of an indication of what the next year will look like in terms of everything that's going to be communicated. So the communication will come from Unum to Mercer as we'll start thinking through what the rate impacts are going to look like and what that member communication will look like with those plan options. We will work together with the OEB team to ensure that that communication looks good before anything goes out to the insureds. And the drop date today that we're expecting for that first insured communication will be around August 1st of next year. So the members will have a little over a month and a half in order to make some decisions before those first bills are going to start to hit the system and generate. And then that initial rate increase will be effective 10/1 of 2025. Members will also have the ability to make decisions about whether they want to keep the plan or if they want to forfeit the plan all the way until the 29th of January of 2026. So there is still about a 120-day runway that they can make that decision without completely forfeiting the plan as well. So there is a decent amount of time. All right. And then lastly, as we start to look at considerations for the current state. So the current state we talked about is we know that we're dealing with this 110% increase. The members are going to have the ability to make a decision on what makes sense for them financially, on if they want to keep the plan or make changes to the plan. And then this group plan is set today to remain open. So new enrollees can come into the plan. This plan is still administered via payroll deduction by OEB. Nothing is changing with this current state. But things to think about in the future as we're facing this kind of larger than average increases. Does it make sense to continue to offer this plan, or does it make sense to freeze the plan, allow employees that are currently participating and members that are currently participating to keep that, but then move them to a direct bill situation so they can still keep the plan and then pay for it on their own, so you're not administering and having the communication aspects that are associated with being the policyholder and the communicator of that plan and program. So the other thing to think about, as I mentioned earlier, was, does it make sense for us to think about, if we really see the value in offering a long-term care plan to your members, does it make sense to put a newer type option in place that has a lot more rate stability and fits the needs of your employees maybe in a different way? So just a couple of things to think about for the future is, do we change the way the plan is administered? Do we change the way that it is billed to take some of the administrative burden off of the OEB team? And then does it make sense to think about kind of future state of this long-term care offering in general? So that's what I had. Are there any other questions? Okay.
All right. Thank you, Rachel.
You're welcome.
I do have a question, Mr. Chair.
Oh, go ahead.
Maybe just a thought. You mentioned that there's current legislators or an individual or language, the reference from Washington. I am not familiar with that, so maybe if you could share with us, when you can, that language, the language from Washington, or a draft of the current proposed or draft form of the legislation, just to be familiar with. More of a background. Thank you.
Yeah, you're welcome. I'm happy to do that. And I don't have a lot of the background information. It's just one of the states that we have on our watch list because there has been discussion around, does it make sense for the state of Oregon to follow the path of what Washington and some other states are looking at? So I will pull some information together and get that over to the board.
Thank you.
Just a quick comment on that, because I think that it's going to be important to see if this starts moving in Oregon, because if it does, you're going to want to move quickly because of what happened in Washington. It was a bit of they had their challenges because essentially the carriers weren't ready for the volume that they were receiving. So something that we'll keep on our radar. Thank you.
All right. Kirsten, you want to run through the retreat agenda for next month, which is an in-person meeting in Salem?
Yeah, thanks so much, Bill. We're super excited to see you guys in person. For the retreats, we really try to have as many breakout groups and discussions as possible and as few slides as possible, just to give everybody the maximum opportunity to talk with each other and voice your ideas and really set a thoughtful strategy for next year. We're going to follow the flow from the December 2022 retreat because we know, and we've known now for a while, that we need to come back and set new board goals for the upcoming 25, 26, and 26, 27 renewal seasons. So we'll spend the morning in small groups brainstorming goals, and then we can come back together, share thoughts, and then make a consolidated list and vote and come by a new set of goals. And then in the afternoon, we'll come together and talk about what clinical strategy we want to set for the upcoming OEB renewal. And so we'll walk through OEB's data so you can understand what conditions and issues are impacting OEB members the most. Where is the plan spend being directed? How many patients are being impacted? And then we also will want to regroup a little bit on what's been done recently, because OEB has a lot to offer its members. And so we'll kind of talk about that. And then that leads you through some prioritization exercises for setting the renewal strategy for the upcoming plan year. And then just to let you know what happens to that. So the board, just to go back to some slides that you saw earlier in the afternoon, the board will set the direction for the strategy, and then Mercer and OHA staff and your carrier partners and all of the committees that serve you will take those as marching orders and begin to execute through. We have lots of different avenues. So we'll start exploring what ideas we want to bring back, what programs, any financial things we want to talk about, and then we'll start to bring those in front of you in February.
Your slide brings up a memory that driving down Lancaster Avenue to Chipotle, standing in line and getting back in 30 minutes was a tall order, was a challenge, right?
Yeah, we hope to have
that didn't work.
Chipotle there for you this time, Bill.
Oh, okay. So I was thinking okay, so lunch is going to be right at the meeting room. Got it. Okay, never mind that. Disregard that comment. But yeah, I remember we were like, rush, hurry. Right. Okay.
Yeah,
never mind.
it was.
Good. I found my big book that you gave me last year at the retreat. Just found its way to the top of a pile just recently. So, questions, comments? Do we have any public comment, Rose?
No, Bill, no public comment.
All right. Anybody have anything they want to close with at the good of the order? Don't see any hands. Ollie.
Yeah, just a quick comment. So the board heard a lot today about joint work groups with PEB today. I just wanted to add some context behind these joint initiatives. So back in 2017, Senate Bill 1067, that was the bill that actually established the 3.4% caps, and it also established a 200% hospital payment cap, which has really has been beneficial to PEB and OEB both. But it also mandated a report looking at the merger of the PEB and OEB boards. And ultimately, the report found that creating joint work groups that focused on leveraging purchasing power as well as data while keeping the independence of the boards is a much better alternative. And so that's kind of been the push the last few years to create the Joint Innovation Work Group and Health Equity Work Group, and then looking, even at CO and opportunities there. So I did want to give a little bit more context and give the board a little more understanding behind the impetus for doing that. And with the legislative session, a long session coming up, they love when we talk about efficiencies and how we partner together and on some of these initiatives. So that's it.
Thanks, Ollie.
Yep.
All right. Hey, we're on time. Literally. All right. With that said, I will adjourn the October meeting of OEB and see you all in Salem. Looking forward to meeting you all in person. All right. Thanks for coming today.
Thank you.
Thank you so much.
Bye.
Thank you.
Bye.
Bye, everyone.
Thank you.